We are live.
So a very good morning, a very good evening to one and all present here. We heartily extend our welcome to the grand rounds of the pediatric department. So it is said that the greatest challenge in medicine is not always curing the obvious, but understanding the enigma of the unexplained. With that, we come to our topic for today's grand rounds, which is unexplained to explained. So the presenters for today are myself, Dr. Malvika, and my colleague, Dr. Navya, and our moderator for today is Dr. Sowmya ma'am. So in medicine, just like in a Sherlock Holmes mystery, we have the statements of parties at the crime scene. We have the clues, and we have the culprit. With the clues, we help in identifying the culprit. So just like that, in medicine, we have the history and the clues, which are the clinical signs, which help us to identify the diagnosis, which is the culprit. So with that, let's start with our solving today's mysteries. In our first case, we have a 31-year-old lady with blurred vision in the left eye since 1 week. She also gives history of images getting superimposed over one another. Coming to her examination findings, she had normal vision, that is 6/6 N6 in both eyes. Her pupillary examination was normal. Her anterior segment and fundus examination was also normal. And her contrast sensitivity was 2.1 log units, which is normal. Her alternate cover test was also orthophoria for distance and near. So all the examination findings were normal. So what is unexplained in this patient? So the visual symptoms of the patient is unexplained in this case. So what do you want to do about it? What next for this patient? How would you like to proceed? These are the options you have. Do you want to go and do an investigation? Do you want to correct her refractive error? Do you just want to reassure her because you found all the examination findings to be normal? Or do you want to do an orthoptic evaluation? Or you want to further explore the history? And for any of these, does anyone want to take an answer?
Raise their hands. None of you want to do any investigations further. Anyone who would say that we would want to do a cycloplegic refraction and correct her refractive error? I would want a raise of hands quickly. None of you thinking of that. So we send the patient home, tell her that everything is okay. No? You want to do an ortho-optic evaluation? What do we do? Further explore the history?
So we have the majority
40% telling explore the history, right? 60% still thinking what is unexplained. Do we need to do anything about it or otherwise? Proceed.
So let's proceed. So like most of you answered, we did decide to further explore the history. So in any case, when we have these unexplained visual symptoms like vision loss or blurred vision or vague visual symptoms, we must always further expand it and ask them if it's uniocular, is it binocular vision disturbances, is it sudden in onset, is it chronic, especially which distance does the patient have a problem, or any specific activity which poses challenges to the patient, any associated symptoms like photopsias, metamorphopsias, any headache, nausea which might be associated, any noticeable field defect in the patient, or look for any other signs of neurological conditions or any health issues which might be leading us to the answer. So on further exploring the history, she gave history of not being able to visualize one side of her mobile screen. And she kept insisting that these vague visual disturbances are consistent. And when we asked the same questions to her, she specifically said that these are happening when she's looking for near and specifically for this particular activity. So then, because of this history that she gave, we went and we investigated further. So we decided to do a Humphrey field analysis for her. And here are the 30-2 fields for her. We notice that the foveal threshold is normal, and the grayscale and the is not showing any noticeable defect. But in the pattern deviation plot, we can see that in both the eyes, there's a central point involvement. In the right eye, it is in the nasal field, and in the left eye, it is in the temporal field, but it's respecting the vertical, mostly respecting the vertical meridian with few spillover points onto the other side. Because of the involvement of these central points, we decided to do a 10-2 also for this patient, and these were also reliable fields. And in this, what we found was that respecting the vertical meridian, we found that she was having visual loss in the temporal field in the left eye and nasal field in the right eye, corresponding to a central homonymous hemianopia. So we know that the macular representation in the visual cortex is located at the tip of an occipital lobe, and that usually presents as the central homonymous hemianopia. Knowing this, we decided to understand why this patient is having this hemianopia.
The first two rows on the left side, any comments on, if you can just say anything more about left, the central homonymous, left homonymous hemianopia, anything else that you are noticing in that? Anything more specific that you're noticing there, apart from it being central and it being left homonymous? In the
it looks incongruous.
Yeah, it is not congruous, it's incongruous visual fields. Anything more? Exactly. Which quadrant being involved? So where do you expect the lesion to be? Superior where? You're looking at the parietal lobe, occipital lobe, temporal lobe, where exactly? It's a 10-2 field. Remember, this is a 10-2 field. We are not looking at a 30-2 field. Where do you get a central homonymous congruous hemianopia? The broader localization. Is it in your temporal lobe, occipital lobe, parietal lobe? It's in the occipital lobe. Which part of the calcarean fissure? Superior, inferior? Inferior, so it was going to be reverse. Superior part of the calcarean fissure. Okay, continue.
Because we know that the central homonymous hemianopia could have an occipital tip lesion, we decided to do neuroimaging for her. And on T1 imaging with contrast enhancement, we found well-defined round to oval peripheral ring enhancing lesion with altered signal intensity lesions in the right occipital region with surrounding diffuse perilesional edema. With this, we referred the patient to a neurologist for further management. The differential diagnosis was either a neurocystic sarcoma or a tuberculoma, and she's undergoing further treatment for the same. We have not been able to review her post that. So we had a patient where we had unexplained and unusual visual symptoms, which we have explained by the elaborate history and the investigations that we have done. So what have we learned from this case? So it is very important to take a detailed history, and any unusual visual symptoms may have completely different causes, and we should never dismiss or disregard the patient's symptoms without finding the cause. So listen to your patient. He's telling you the diagnosis. This is the famous saying we all learned in medicine by Sir William Osler. So this aptly applies for the case in question. So let's proceed to the next case.
Good evening, everybody. Let's move on to the case 2. Her 47-year-old male who came with the complaints of blurred vision for the near, with the complaints of headache on and off. Though he was using the glasses, he was not comfortable with the glasses. He was evaluated earlier also, and he was told he had refractive error, though he was not happy with the refractive correction, which was given to him. On examination, we found out visual acuity was 612 and N8 in the right eye and 69 and N6 in the left eye. Pupil, there was a RAPD in the right eye and rest of the anterior segment examination was normal in both the eyes. On fundus examination, we found out there was a temporal pallor in both the eyes. So what is unexplained in this case? So, as you all said, decreased visual acuity and temporal pallor which is present in both the eyes was not explained. So what would you do next? Okay, color vision and contrast sensitivity was done in this patient was within normal limits. So here we ordered a 30-2 for him. The fields were reliable, which showed field defects in the temporal half in the right eye and in the left eye, which was respecting the vertical meridian with a spillover to the nasal field only in the left eye, which was suggestive of a bitemporal hemianopia. So, as it was a classic bitemporal hemianopia, we went ahead and did a MRI imaging. As we can see, here in a T1 post-contrast image, a pituitary adenoma was identified and he underwent a transnasal and transsphenoidal excision of the tumor. Coming to the third case, a 41-year gentleman who had a blurred vision.
Hemianopia in the first. We talked about homonymous hemianopia in the first case. What do we call this hemianopia as? And it is a bitemporal hemianopia. Heteronymous hemianopia. Where do you localize the lesion in a bitemporal or a heteronymous hemianopia? Sorry, one answer. Somebody in the mic loud. Optic chiasma. Can we predict the chiasmal location like a prefixed or a postfixed chiasma looking at the visual fields? Yes or no? Yes. So how do we predict it? What will be your visual field if it is a postfixed chiasma? Let's say postfixed chiasma affects what? Does it affect your optic nerves? Does it affect your optic tract? One answer. All of you say that all of you agree postfixed is affecting the optic tract?
So coming to the case 3, as I
Prefixed or a postfixed chiasma, depending on what? The chiasma in relation to the pituitary gland, which is there down. It's not about the lesion. If it has a lesion, it is prefixed, would have your tract involvement. If it's postfixed, it's going to have your nerve involvement. It's a reverse of what you were trying to tell me. So that again gives you a clue with regards to the visual fields. Though this patient had a classical bitemporal hemianopia, what is the symptoms the patient will otherwise have? This patient didn't complain anything. What is the classical symptom that the patient will come to you with a bitemporal hemianopia? Driving difficulty, okay. Anything else? There is no overlapping visual fields at all. So this is going to be more disabling to the patient compared to your homonymous hemianopia. Homonymous hemianopia can have a what to compensate for the visual field loss? He can have a abnormal head posture. He has a left homonymous hemianopia. The patient will have a left face turn to center his right field, which is remaining, compared to you having a heteronymous hemianopia, where the patient can't adopt any head posture to get rid of his visual field loss. Homonymous or heteronymous refers to what exactly? The side of the visual field involved. If it is the same side of the visual field, it's the left of the left eye and the left of the right eye getting involved. That's your left field involved. So then you call it as a homonymous. If it's different fields in either of the eye, right of one eye and the left of the other eye, then you call it as a heteronymous visual field loss. Okay, proceed.
a 41-year-old gentleman with blurred vision in the left eye who was diagnosed keratoconus in the right eye and was undergoing orthoptic treatment in the left eye.
That whenever you have a blurred vision on left eye, the refractive error is equal in both the eye. The patient does not have a squint. Do you think this patient would have a left eye amblyopia? Raise of hands. What is the most important, crucial point for you to diagnose amblyopia in any particular patient? Okay, the patient should have a decreased vision. Then no structural abnormality, which could explain the visual loss or correlating with the visual loss. 3. What else is most important to say that the patient has a amblyopia or a lazy eye? Only these 2 things. The eye looks normal, the vision is lesser. I can call that patient amblyopic.
Fundus examination.
What else should be your criteria to diagnose amblyopia? Okay, I asked the question the other way around. What are the types of amblyopia? In the mic, please. Louder. Sensory is not used anymore. Okay. Sensory deprivation amblyopia. What is this classification based on? What is it based on? You're telling it as anisometropic, strabismic, or based on what are you classifying? Based on the cause for the amblyopia. So whenever you're diagnosing any patient with amblyopia, there has to be a cause which is detected in the patient. The patient should have axial indifference or an anisometropia which is detectable for you to say that the patient has a lazy eye. The patient should have a manifest or a latent strabismus for you to detect and say that this is the cause for amblyopia. Or the patient should have a history of sensory deprivation in childhood, a corneal scar, cataract surgery done in the past, a ptosis which has been corrected. And that can explain this. So without a cause for the amblyopia, you're not justified in saying any patient as amblyopia or diagnose any patient as amblyopia. Why that is important is because of this particular patient. This patient was undergoing an amblyopia therapy for the left eye for a visual symptoms which is only for 8 months. So no patient should ever be referred to vision therapy or amblyopia management without knowing the cause for it. It's not like a diagnosis of exclusion. It is a diagnosis of exclusion, but it's not like you don't find a cause, so you put it as idiopathic. So I don't find a cause for vision loss, I call it as amblyopic. That is not how it is. So this patient for the last 8 months was on amblyopia management. So that has to be very, very clear. So please don't write it as amblyopia unless you know the cause for it. If you're not able to find the cause, always refer it to us. We are here.
So this patient was referred to us by cornea clinic for unexplained visual acuity in the left eye. Though, as we can see in this oculizer, the keratoconus was evident in the right eye, there was no evidence of keratoconus in the left eye. Thus, the decreased visual acuity in the left eye was not explained. So, as we learned from the first case, we went back and we explored some more history. There was history of noticing discomfort in the left eye along with decreased contrast since 8 months. There was history of tinnitus. There was history of arm twitching and right medial motor axonal neuropathy. And there was an MRI with cervical spine was done with C5, C6 disc bulge was seen. He was also on treatment for hypercholesterolemia. Then we learned that we are dealing with a patient who had a decreased visual acuity in the left eye with multiple neurological symptoms. On exam,
that part, sleep becomes irrelevant. Sad to know that we are not
Just
just
dealing with one symptom in this patient. The patient probably has multiple things in the past which needs to be explained. As what we have always learned in medicine, there will be one diagnosis to explain multiple symptoms. It cannot be like you have multiple diagnoses for multiple symptoms for the patient. So that is why your history exploring again becomes very important.
On examination, there was 6-6 and N6 vision in the right eye, 6-12 and N6 vision in the left eye, and 3 mm pupil. And again in the left eye, the pupillary reaction was ill-sustained, and rest of the anterior segment in both the eyes and fundus examination was within normal limits. Color vision and contrast sensitivity was within normal limits. So, as I mentioned, what is unexplained in this case? So, decreased visual acuity in the left eye. So, what next? Here,
Want an answer. I would want an
Answer from all of you. What do you want to do for this patient now? I'll give you the background that this patient is not amblyopic because the axial length was comparable. The patient never had any history of ptosis surgery, nothing done in the past which could explain a sensory deprivation amblyopia. The patient was not having any squint per se. So this is not amblyopic patient.
patient had a similar refractive error in both the eyes, which was cylinder.
Visual fields, okay.
Here, we ordered a 30-2 fields for him, which was reliable and showed a few isolated defects in the temporal half in the right eye and isolated defects in the temporal half with a spillover to the nasal field in the left eye, involving the central points. As the central points were involved, we went ahead and did a central 10-2. As we can see here, the defects were in the temporal half in the right eye, and in the left eye, the defects, visual field defects were in the left half with the spillover to the nasal field were noted.
Again, what does this suggest
Towards? How is this different from the first case or the case 2 that she presented? One at a time. What was there in the case 2 which is absent or which is not seen here? Or compare the visual fields of case 2 and case 3. Other eye on 30, go back to the previous field. See here,
30-2.
see what you're exactly seeing is non-edge point. There are 3 or 4 cluster points which are respecting the vertical meridian in the right eye. Is that clear? In the central field. Compare it with the left eye. Again, there are non-edge cluster points of defects which are there in the temporal half of the left eye. You also have defects in the inferior visual field. Okay, though it is not classically respecting the vertical meridian in the left eye, you have visual fields which are involving the temporal half of each of the eye. Then because it is not respecting anything and the central fields are involved, you need to do a 10-2. So any patient which has a central defect, which is a non-edge point, and there are 1 or 2 defects, or the defect is less than 0.5%, you always have to do a 10-2 in addition to 30-2 to understand what is the morphology of that defect that you're seeing. Exactly. Is that clear? That is why 10-2 was done in case 1. That's why it is done in case 3, which was not done in case 2. Because 30-2 is already showing a complete field loss of temporal half of both the eyes. Okay. So this 10-2 again confirms that it's exactly respecting vertical meridian in the right eye, and the defect is involving the central field. That is why the patient is having visual loss in the last 8 months. The right eye visual field, did you mention about the keratoconus?
Yes, ma'am, I mentioned about
So right eye vision has been poor. Probably it is masked because he has a keratoconus also in that eye. And that is why that right eye visual fields has not been taken into consideration for him, though he is able to read 6-6 in that eye with a cylindrical correction. So now again, you have a similar patient. It's a bitemporal hemianopia. The only difference being it not involving the entire half of the visual temporal field, but involving only the central 10 degree. And that's why the visual complaints are localized to the left eye.
So, neuroimaging was done, and we could see a pituitary adenoma with a chiasmal compression. And he underwent transnasal and transsphenoidal excision of the adenoma. Though both the cases had pituitary adenoma and both underwent transnasal or transsphenoidal excision of the adenoma, the postoperative results were different. As we can see in the second case, the visual acuity was not improved, whereas in the case 3,
Your visual acuity in case 2
was 612, 69. So it has improved by one line, which is 69 N6 in the right eye, 6 parts and N6 in the left eye. Unlike in the case 3, where the visual acuity in the left eye was 612, it has come back to 6 N6.
With the fully recovered visual fields in the case 3.
In the subsequent slide.
So, with the fully recovered visual fields in the case 3 and residual field defects present in the case 2. So, early identification of the cause of the unexplained visual loss and evaluating the dispallor and early visual assessment help the case 3 patient to recover the vision and the visual fields. So, this is the patient 2 visual field 30-2, where there is
the same
Patient's field, which is the 30-2, which had a bitemporal hemianopia, completely involving the temporal halves of both the visual field. This is 3 months post-surgery. Now, what are you seeing here? What's happening in the right eye? Defect still involving in the central, and the right eye inferior fields seen better recovered compared to the superior field. So if you remember how we learned it, the way it progresses in a visual field loss starts with supratemporal and then goes clockwise, and that it has to recover the same way. So your inferior fields would recover first than your superior fields. So that is how it will recover.
So as we can see in the case 3 patient, the visual fields were fully recovered.
It's exactly the same
Patient which had a left eye having temporal and inferior fields, and the left eye having only the central visual fields. This is completely recovered on a 30-2.
So as we discussed earlier, usually chiasma lies over the pituitary adenoma in 80% of the cases, whereas it lies over the tuberculum sellae in 20% of the cases, with 5% being lying over the dorsum sellae. Depending on the site of involvement of the chiasma, we can see a defects. Usually at the junction of the right optic nerve, in this case, and the chiasma, we can see a junctional scotoma. Right at the chiasma, we can see a classic bitemporal hemianopia. At the posterior chiasma, we can see a central bitemporal hemianopic scotomas.
And this again becomes important as how you saw
In
it.
the case 2. The first picture represents exactly how you saw in the case 2. The second picture is akin to what we saw in case 3. So you can have a central bitemporal hemianopia, or you could have a complete bitemporal hemianopia. So either of it is a possibility. The case 3 was referred to as by Dr. Pallavi because the patient had sought opinion at our institute for the keratoconus, since she thought that there is no keratoconus in the left eye, and that's why it was referred to us. That's why we went ahead and did the visual fields for this patient.
So we understood that visual field is an important tool in diagnosis and management of pituitary adenoma. Even a subtle superior temporal defects respecting the vertical meridian may be the first sign at times. Visual field is a repeated post-surgery, usually 1 to 3 months, depending on the clinical presentation, lesion characteristics, type of intervention, and patient's visual complaint. Visual field improvement following the surgery can occur few days to few weeks, that is early recovery, or few weeks to few days, and few months to few years. There are documentation as long as up to 5 years post resection of the tumor recovery has been seen. Recently, the preoperative macular ganglion cell and inner plexiform layer thickness is used as a predictor for the visual field outcome following the decompression surgery for the chiasmal compression.
Why visual field recovery in the third patient versus the second patient? It depends on the duration of compression. One, if there has been a nerve fiber layer loss or a macular GC, IPL thickness, which is correlated with it. Again, that does not is not an indicator for vision improvement. That's an indicator for visual field improvement. So if there is, the cutoff is approximately as what she's mentioned there, 85 3 microns for an RNFL thickness, and GCIPL is around 77 micron. So anything less than that would have a poor visual prognosis. Compared to that, higher than that, macular thickness would have a better visual prognosis. Again, it depends on the duration of compression. It's not directly correlated with the optic disc pallor. So though age of the patient, duration of the patient, the presence of necrosis in the tumor or otherwise, having a surgical edema post-surgery, all that has prognostic factor, not apart from these things which we can pick it up in the eye to say if the visual field is going to recover or otherwise. So the highlight of case 2 and case 3 is to pick up at the right time. If you pick up at the right time, the vision and the visual field both are going to recover. If you don't pick it up at the right time, the visual field may improve considerably, but the visual acuity is not going to improve. You're going to land up with having a lesser vision, apart from him having other compression and other changes because of the tumor per se.
All this patient, this was not so how you need to also.
Yes, ma'am. We have started documenting RNFL. The only problem with RNFL will be optic disc peripapillary RNFL is what is taken into consideration. So if you don't mark it properly, then it does not correlate exactly. So marking it exactly becomes important. Now the more stress is given on macula GC-IPL thickness rather than nerve fiber layer thickness. Macula GC-IPL is known to correlate much better compared to RNFL. Yes, ma'am. That has to be done as what is.
Each machine or each it is an SDOCT, SSOCT. The thickness varies. Whether it is
It does, in a sense, like the previous studies were done with the SDOCT, unlike the newer studies which are done with the other OCT. In both the things, they have undergone there is a significant correlation. Probably the correlation ratio is a little different in both of them, but both of them have a cutoff value. It is not like a direct correlation. There is a cutoff value beyond which it does show improvement. Less than that, it does not show an improvement. That's how it is being noted.
So what
It's
we are
not
suggesting
exactly.
is a direct correlation between visual fields and RNFL
It's
or
like
GCC
you have a
loss or
macular GC-IPL thickness of 77 microns and lesser. On patient, those patients want to recover lesser compared to any patient which has a thickness more than 77 micron. Again, the visual field improvement, what we are talking of is like they have a criteria for visual field improvement. It's not like normalizing the visual field. If there are more than 3H cluster points, those 3H cluster points are going to reduce it to 2 or 1, and the mean deviation is going to get better. And the difference is less than 0.1% would become less than 0.5%. All of them are considered as improvement. So it may not be as dramatic as the third case, is what we saw, or even in the second case, but it does definitely show an improvement.
so whether in our cases did we do the
Yes, we have done it. I didn't put that up because that was, I thought that would be beyond the scope of this talk, because what we are highlighting is explaining the history and explaining the patient's symptoms, like what is unexplained. These are the things you see in the general OPD where you have a 6, 12 and 9 vision. Like the case 2 has come multiple times. He has gone to various hospitals having diminution of vision, because the patient is 47-year-old NS1. So vision is okay to have a 6/9 vision and discard off. So he was bewildered the moment I said, you need an MRI and you have to go to the neurosurgeon at the earliest. So that's how it happens. So that is why you have to correlate whatever you're seeing with what is seen on the vision, because those are the two important things that we have in our.
whether it should be always first and then the OCT or the RNFL, because
Either way, it is okay, because what we are looking at is two different defects. One is structural defect, the other one is a functional defect that you're
I
looking
think the
at.
structural, I think the OCT should show before the field defects, because field defects take time. Because as she said, in our the thickness already reduced. So naturally the field effect, I think the GCL will pick up earlier than the visual field.
Correct.
Because why I'm saying this, because the hydroxychloroquine toxicity also, the field effect, when it comes already, the structural damage has taken place. But if you do an OCT and you're picking up, your GCL thing has come down, but it may not show the visual. So that's the time that already the defect is. So I think the macular GCC
Unless we
is,
have a optic disc failure, then we have nothing to say
that's
why
what
we
I
are doing a
correct,
macular
exactly.
GCIPL. Like in the second patient, we have a disc.
Whether it should be a rather than doing an HLP, whether OCD could be a screening tool, whether that is what can be expected.
I would prefer that both of them are done. Like you're seeing a patient, the first you explain the visual field. If the visual field does not show anything and you still have something to explain, then go back and do an OCT. If you have this, then do both. Like both the patients, we've done both of it.
The color vision was normal in the second patient.
Yes, ma'am. Color vision is
No,
normal.
now I have basic question, like when does now, we know the optic nerve head is affected, but why is the color vision and contrast normal in this?
The vision is dropped in the second case, ma'am. No, it's not
Correct.
necessarily that color vision and contrast show.
No, I
a
just want
difference
to
in-
know, it's for the everybody's sake,
Yes,
like
ma'am.
when do you,
Need not
because then
necessarily that
sometimes when you,
color.
yeah.
Need not be that we have clues on a color vision and contrast all the time, especially in these kind of homonymous defect or a bitemporal defects. It may not show it up. If it is showing on color vision and contrast, we would definitely have an RAPD, which is like a grade 2 or an above RAPD. All of them have a null sustain or a trace RAPD, where it's still a possibility that it will recover, and that's why not showing up on other tests of optic nerve function.
So let's come to the last case of our series of unexplained cases. So we have a 58-year-old lady who came with complaints of blurred vision in the left eye for the last 8 months. She had already been diagnosed as optic atrophy elsewhere, and the poor prognosis of the same was explained to her, and she was told that it's better that you leave the left eye alone. Just like we have learned in our previous cases, and by now we know that we need to further probe the history. So her past history was suggestive of trauma 4 to 5 years ago, following which she had complaints of mild dizziness. At that point, CT brain was done, according to her, but she didn't have any reports with her. On examination, what we found was that in the right eye, the vision was 6/6 N6, with the pupil reaction being normal, and the disc was normal, and we found chorioretinal atrophic patches along the infratemporal arcade. While in the left eye, we had a vision of 6/36 N14, along with an RAPD, along with disc pallor, and similar chorioretinal atrophic patches in the infratemporal arcade. All of this suggestive of the optic atrophy that she had been diagnosed with. So what is unexplained in this patient?
Diagnosis. She's come to with a diagnosis, and she just has come in for a regular eye checkup. She knows that she has a left eye optic atrophy now.
Yeah. Type, yes, we don't use type, but what else? Yes. So the cause of optic atrophy was something, she was just told to leave it alone. So there was no further investigation done to identify what had caused her optic atrophy. So what to do next? Now we know she has optic atrophy. What would we like to do next for her?
What do we do for that patient? (636) vision. What visual fields? If you're thinking in terms of visual field, what do you want to do? You want to do a full field with, you want to tell the optometrist anything else with regards to the stimulus size that they have to be using. Use the largest stimulus size which is available in your perimeter. Use a size 5 stimulus and do a visual field. You want to do the visual field of the left eye or the right eye or both? Both. Doubtful or clear? Both. You want to do a visual field of both the eyes.
Just like that, we did the visual field in both. We did the best, largest possible field that we had, 76-2 in the left eye. So we showed gross field effects, sparing very few areas in the left eye. While in the right eye, the 30-2 similarly showed gross field effects, sparing only part of the inferior field. So we went ahead and did a 10-2, which showed a classical central scotoma in this patient. So gross vision loss in one eye with central scotoma in the other eye, what is it suggestive of?
Optic atrophy in one eye, other than central scotoma. Cause and condition when the patient has an optic atrophy. Foster atrophy or you can have a pseudo-foster atrophy. So that is what problem. So that is what you're having a vision loss in one eye, other eye having a central scotoma. What you're looking at is a foster canopy. Anything else that is a possibility? We had series of adenomas, right? So any adenoma which can cause similar to this, vision loss in one eye, small defect in the other eye. Prefixed, post-fixed, where?
Fixed. The junctional scotoma that we mentioned.
Not classically superotemporal is what it represents, not like a central scotoma, but yes, that is again a possibility that you're thinking of.
So to rule out what we had, we did a neuroimaging, and the T2 weighted imaging showed extra-axial enhancing mass in the anterior cranial fossa with mass effect over surrounding structures, with the optic chiasma also being involved, suggestive of an olfactory groove meningioma. So what have we learned from this case? It is very important to evaluate the cause of optic atrophy. Whenever we see a case of optic atrophy, the cause could range anything from a compressive optic neuropathy. The cause could be toxic, nutritional, infectious, hereditary, could even be certain neurodegenerative disorders in certain retinal dystrophies. So, like we did in this patient, neuroimaging is important, and in certain cases, blood investigations also form part of our tools to help in diagnosing the cause of the unexplained optic atrophy. This case highlights why it is important to identify a cause of optic atrophy, one to help to identify the etiology itself. The other is to prognosticate the other eye. In this patient also, the other eye is what helped us to diagnose the case. So it's also to prognosticate the other eye. So here we had an unexplained optic atrophy, and with the help of the clues we had, we could identify the cause of optic atrophy. So to conclude, whenever we have unexplained,
similar to amblyopia that we
Talked about, we always have to have cause. The diagnosis cannot be the writing diagnosis. It has to have a why and what next to the patient. That has to be clear to the patient. If you're taking the patient having optic atrophy, you have to say that this is the amount of risk that you have, that the same patient can happen in the other. This is many years, and this is a prognostication for you. This is when I would follow. The golden rule in any case with vision loss that it is not explained by a structural lesion, like retinal condition. The patient has a vision loss in one of the eye and you don't know what is happening. Please do a visual field in the other. We've had any number of cases like this where the patient is diagnosed with amblyopia in one of the eye and on the they come back having a mass lesion.
The first in the case series, I think, a decade back, what we had is a data which is causing a vision loss from her. So, which was picked up on the visual field in the other eye. So, you have vision loss in one eye and you don't know why is it. Then do the visual field in the other eye before you said that this is what is the cause for it. That is the first thing. And two, never discard any symptom of the patient. The patient says something, please elaborate on it. Because most of you on history taking is only diminution of vision left eye. What, when, where, why, thing is there in your history. So history becomes the first point in your neuroophthalmology work or in general ophthalmology also. Your vision has to be in detail written, only then proceed with next. And please don't order any investigation without doing detailed investigation. tell the patient this is why I'm asking this visual field and this is what I'm looking for. So this patient would have probably landed up with other eye complication or landed up with another complication had this not been picked up, and she's been living with it. She knows from very long time that she has an optic atrophy in one eye.
So we had a series of patients who had unexplained visual symptoms, vision loss, and clinical signs. So whenever we have such patients, it warrants a detailed history taking and a neuro-ophthalmic evaluation. So like our Sherlock Holmes, we have, with the help of clues, history taking, we finally identified the culprits and explained the unexplained. So always remember that there's always another story and there's always more than meets the eye. So yeah, a word of caution, it doesn't mean we do fields in every patient. We have to have proper basis to why we are doing that. And we have to first take a detailed history and
Yeah, tomorrow the appointments are all full and I can't get my own patient's vision fields tested and every patient is very different. You need to understand the essence of the stuff is the history which is to be elaborate whenever you're taking it, and please correlate whatever you're finding. You're having NS2, NS1 cataract and you want to correlate it with 6/9 vision, N6 vision, N8 vision. Is that matching with it? Every clinical sign should fit into the symptom like your jigsaw puzzle. Your history is one part of the jigsaw puzzle. The clinical symptoms or signs is one. The investigations that you get and diagnosis, all of it should fit in to solve the puzzle. That's what is the essence of medicine. The essence of medicine is to solve the puzzle. So think it that way, is to explore more such cases. It's not like we found this over years. All of these cases we have probably diagnosed in the last 8 months. Back to back, we had a series of cases similar to this. So thanks to all who have been, thanks to all of them who have been careful in the neuro-ophthalm. I think the second case was referred by one of the general ophthalm fellow here to neuro-ophthalm department. The case 3 was referred to us by the cornea consultant here. So the first case again was referred from the general ophthalm. So I hope our OPD induction has worked, that they have been referring it to the neuro-ophthalm clinics. I think I think